afternoon, all. My name is Michelle Clark from JSI. I'm the project manager for the Data to Care TA project, working with the Centers for Disease Control and Prevention. We want to welcome you to today's Data to Care TA webinar entitled Creating Integrated Health Department Data Systems to Support Data to Care Activities. This webinar came about based on a TA need identified by one of the health departments participating in the TA project, and we're happy that so many other health departments that we're working with found it of interest and value. This is the last webinar as part of the Data to Care TA project webinar series with JSI, and we're really happy that David Heel, who I'll introduce in a moment, was willing to present today. This call is being recorded in case you wish to share a recording with your colleagues who were unable to attend the webinar or reference it in the future. So if people wouldn't mind putting their phones on mute unless they are speaking during the question and answer discussion time, that would help with the quality of the recording. So I, again, wanted to introduce our speaker for today's webinar. David Heel, who has a master's in social work, is the Retention and Care Coordinator at the Washington State Department of Health Office of Infectious Disease in the Infectious Disease Prevention section. A case study about Washington State's Data to Care program can be found on the online toolkit at effectiveinterventions.org if you'd like more information about Washington State's Data to Care implementation activities. Thank you, David, for your willingness to share your health department's experience planning an integrated data system. We'll have brief introductions in a moment, and then David will present for about 20 minutes. This will then be followed by a question-answer discussion period. We wanted to start with brief introductions by the JSI team, the health departments who are on the line, and then CDC. So again, I am Michelle Clark, the project manager, and also working with the Massachusetts Department of Public Health. Other colleagues on the line.
This is Jeremy Holman, the director of this project.
Hi, this is Jean Day, and I am one of the technical advisors working with the states of Maine, Colorado, and South Carolina.
Hi all, this is Julie Powers, and I have been working with Hawaii and Florida throughout this project.
Hi, this is Molly Higgins-Biddle. I'm a TA advisor, and I'm working with Virginia.
And this is Amy Flynn. I provide project support for all the TA specialists and the Data Care project overall.
So great. Let's turn to the health departments that are on the call. We'll go in alphabetical order, and not sure who from the various health departments is on the call. So let's start with the state of Colorado.
This is Jennifer Donnelly, Megan Duffy, Maria Chivas,
Elaine Daniloff,
Anita Watkins.
Great. Thank you, Colorado. How about from the state of Florida? Anyone from Florida? No. Okay. Hawaii? Okay, I believe Hawaii is, there's a holiday actually in Hawaii today. Is that right, Julie?
That is correct. It's a state holiday.
Okay, great. From the Maine Health Department?
Brenda Kendall.
Thanks, Brenda. Massachusetts Department of Health?
Hi, this is Betsy Jones.
Hi, this is Christian Haig.
Great. And South Carolina?
Hi, this is Monita Gaskin.
And Janet Tapp.
Great. Hi there, Janet, Monita. And Virginia Department of Health?
Brian Collins.
Hi, Brian.
Child.
I'm sorry, who else
Tammy
from Virginia?
Tammy Woodson.
Great. Okay, did any other health department members join who may have missed the introductions? Okay, great. It's great to have such representation on the team. And we know some of you on the call have firsthand experience developing integrated data systems, and definitely look forward to hearing your experiences during the discussion section as well. So I'll now turn it over to our CDC team. Ms. Rondette Jones is our project officer to introduce the CDC folks.
Thank you. Good afternoon. Can everyone hear me okay?
Mm-hmm.
Oh, great. Okay. My name is Rondette Jones, and I am the technical monitor for this project. I'm also the acting team leader for the prevention and clinical care team, and very excited that so many of the jurisdictions were able to join today's call. Looking forward to hearing the discussion data to care is a hot topic here at CDC, and we are always looking for opportunities to learn more from the jurisdictions, and so excited about the work that JSI has been able to do as well. So looking forward to a good call.
Great. Thanks, Rhonda.
Hi, and this is Kathleen Green. I'm a behavioral scientist on the Data to Care project at CDC, and I am also on the prevention and clinical care team.
Thanks, Kathleen. Okay, so thank you again, David from Washington State. We will now turn the slides, the screen share over to you as a presenter for your presentation.
Okay, can you hear me all right?
Yeah.
Okay, good. I'm not seeing my, are you seeing my screen?
Not yet.
One moment, bear with us, folks, while we're working through this technical glitch.
Okay, I think I got it now.
There we go.
There we go.
Okay, well, thanks, everyone. Sorry for that little bit of a delay. And thank you for joining me this afternoon for a discussion of a topic that's of great interest to all of us. And hearing the roll call of the states, I know that there's some very exciting work going on that I've heard either through the grapevine or through other presentations. I'm really honored to be part of this group today. And also, thanks for the CDC folks who are sitting in. You saw some of these slides when I presented to you in Atlanta last week, so you can feel free to snooze through those if you like. This will be just a little bit different. So I'm going to talk about the Washington State considerations and challenges as we adopted our Data to Care program, which has been going on for a little over 2 years now. And I want to focus my discussion on these 4 areas because each one of these has highly influenced the development of our project here, and how it formed, and is attention to all these areas is really necessary in order to be successful from my point of view. We often talk about the data part of it and kind of leave it at that, but there are real organizational and personnel implications to this work, and the kind of environment that you're doing it in plays a big part as well. So organizationally, I think Washington shared the experience of many jurisdictions in that we were kind of siloed up until a couple of years ago. Our programs pursued their grants and programs independently. We are in the same building, which I think even some jurisdictions don't have that experience. But we didn't plan, deliver, or evaluate our services together. And of course, we reported to different federal agencies whose goals and measures were not well aligned with one another. And then as we moved into this, and we made a decision fairly early on that our disease investigators around the state, both the ones that are here at DOH and also at some of our local health jurisdictions, would be the people that were sort of in the front line of the work to locate and relink people to medical care. And we found pretty early that those people, those disease investigators, really needed some new skills in order to facilitate entry and reentry into medical care. They are extremely good at finding people and eliciting partners and completing investigations. Some of them found it a little hard to change hats at that point, and become a facilitator for care entry. So that was something we needed to pay attention to. Also, our epidemiologists and researchers here at the department were not really used to participating in programming decisions, especially those that change sort of weekly, daily, or monthly, where we need to look at data quickly and make a move in sort of real time. And that was a stretch for them. And then, as usual, when information technologists and program developers sit together, they speak a somewhat different language, and we need to find a bridge for that. And we involve our community-based agencies in outreach testing, and also they deliver a specialized relinkage to care intervention for us. And they are not, or weren't, I think they're getting better, really comfortable with data-driven services. They were much more into looking at processes rather than outcomes. And so, as I said earlier, our existing data systems were developed independently and to serve needs of core surveillance, HIV prevention, and HIV care services. There were somewhat incompatible variables and data management standards across those three services, and our data systems weren't really equipped to support program outcome evaluation. So then, to look at the context in which all this is happening, Washington has a large urban population around the Puget Sound. That's the Seattle, Tacoma area. Also includes Everett to the north. And then we have a couple of other cities in the southwest near Portland, Oregon, Clark County, and over at the extreme eastern part of the state at Spokane, with considerable population and some considerable HIV prevalence as well. But that's all contained in a really vast, sparsely populated rural area. So the opportunities and challenges for establishing efficient HIV continuum services really are quite different depending on which one of these contexts you're looking at. So this is just an illustration of what I just showed you. The part in the oval is the Puget Sound area. Over there to the right-hand side of your screen is Spokane, and down at the bottom is Clark County, Vancouver. So our challenge was to find and build a system that really works for all of these different kinds of communities and make the best use of the available resources. And we ended up adopting a hybrid data to care approach to adapt to conditions in diverse communities. We mean by this a complementary involvement of state staff, local health jurisdictions, community-based organizations, and clinical sites. As you know, there are some distinct models of data to care, and this is our version of a hybrid one. And then we also have focused our resources on those populations and geographical areas with the greatest disease burden. And that meant actually withdrawing quite a bit of resource for prevention services in some of those lesser or more sparsely populated areas. To do this, we faced the organizational challenge of working together, creating teams that could address this challenge, and that meant a reorganization in 2011 to integrate our HIV and adult viral hepatitis programs, and then in 2012, the STD program came into the Infectious Disease Prevention Unit. And in the Office of Infectious Disease here, the Infectious Disease Prevention Services, HIV Care Services section, and the Assessment Unit then began to jointly coordinate a portfolio of services appropriate for all stages in the continuum. So, as I said, in 2010, we all lived in the same building and we're on the same floor. Now it looks more like this. We weren't actually working together for a common purpose and evaluating ourselves according to the same criteria. So we formed a Linkage and Retention and Care Services, or LARCS team, to implement continuum services and to develop new data systems for programs that address gaps in the continuum. Some examples of those are the antiviral treatment and access to services, or ARTIS intervention, one that was developed in Seattle, the Care and Art Promotion Program, which is a relinkage intervention, an information system and associated program, which is locating out of care system. And then as we've begun to work together more and more, we have decided now to bid our programs for the HIV continuum services jointly. So both prevention and care services will be wrapped up in that. So one of the things that helped us address this challenge of reorganizing and managing our resources, and something I'd encourage people to do wherever you are, is to really make some system maps that show you the flow of the work and where the connections are. And then you can pay attention to what really goes on at each one of these connection points. And you can see how things work together and how things might need to be revised in order to work together. And this was especially important for those of us in care services and prevention services to see where we really fit together. So I definitely would. This one talks mainly about initial linkage to care. There is a relinkage loop in there as well. And then from there, we broke it down even further as we looked at things like partner services and how they are involved in linkage to care. And again, we use these system maps to analyze the problem and the work, to look at the flows. These were particularly helpful in explaining this to people in the field, to our other partners in local health jurisdictions, and internally as well. It just helped them see where they fit in the overall scheme of things and what the change was that was going on. And then as we began to change our existing information systems to be better able to track HIV referrals during STD that come from STD partner services, we went into it even further with our informatics staff and explained to them and relearned ourselves exactly how things flow and how things fit together. And this was invaluable in being able to make the changes that we needed to make immediately in our information systems to collect some data that we hadn't been collecting before. And also, this will translate into the development of our new information system that will integrate our STD programs, HIV prevention and care services, and surveillance. We've just purchased the MAVEN system in June, and we'll be spending the next 18 months or so developing that, and that will be swallowing and integrating all of the existing information systems. But having gone through exercises like this, we're much more prepared to navigate that transition. So the one that's most relevant to relinkage and surveillance data to care is the Locating Out of Care System, or LOOC. And this is one that we kind of built from scratch. We start with surveillance data that get dumped into that. And if we don't see evidence of medical care for the past 2 years, or if we see like perhaps one visit in 2 years, which is less than optimum, then that is included in a data dump to the LOOC system, and then cases are open from there. And our disease investigators here at the Department of Health, which work regionally in some of our less populated areas, and then the local ones who are in the more populated areas use LOOC. It's a web-based system to locate, verify, and document the patient contact and their care status. We found that many people that were in our initial data dumps were actually in care, no longer resident in our state. Very few of them were no longer living, but really quite a few of the people that in our initial the population of interest turned out either to it was our information that was false, that they were in care and we just didn't know it because of either defects in reporting or late reporting. So those disease investigators, as I mentioned earlier, then facilitate relinkage to care or refer eligible cases to other re-engagement services such as the CAP intervention or to ARTIS. New data acquiring during these investigations is used to update EHARs and data that are used to better understand barriers to treatment, adherence, and retention in care. We ask some questions during this process that help us understand what's getting in the way of people accessing care or remaining in care. We currently use a proprietary software product that was developed by an organization called DATSTAT here in Seattle, just because King County, Seattle area had been working with them for a couple of years and was using their product, so it was convenient to work with them on this project. But we will not be doing that as we move to the MAVEN system over the next 20 to 24 months. So the big change around here was, as I said, we had all of these different data systems, but different ones of us were looking at different pieces of the puzzle. So we found a way to bring together all of those information systems on one desktop. They're not in one data system at this point. We still have to consult them separately as we work a case in the LOOC system. But this was really unprecedented in our state to be able to pull together all these different data systems and references, and it's really proved to be a powerful tool in locating people who are out of care. So the LOOC process looks like this. There's an EHARS query by our epidemiologists, and that identifies potentially out-of-care cases. Then there's an internal investigation where we further clean the data, and our DIS here in-house eliminate as many cases as we possibly can by looking at the resources that we have available here. When there's still a question of the accuracy of that data or some unknowns, it will go to a local investigation where in some cases our local jurisdictions, the DIS there, have access to electronic medical records or other resources, are more familiar with some of the providers and can consult them directly that we're not able to do here at the state level. So as I alluded earlier, during that investigation, when we discover that a person is still a resident in the state and is out of care, as a part of that process of reconnecting them to care, there's a care assessment where we look at what the barriers are for them getting back into care and use that information to help reconnect them. If our DIS are able to do that at that point, they close the case, and if not, they may refer to some of those local interventions or programs that I mentioned earlier, who in some cases are just better equipped to provide direct assistance. So the internal investigation, this is just a diagram of what happens. As I said, all those are checked. If we can assign a final disposition at this point, we do so, and it's removed from this from consideration. If we're not able to do that, we send it to the county where we believe that we have the best information that the person was resident for a local investigation. And this is all internal. We just press a button in the system and the case pops up in their queue. So following that, there's the local investigation, which, as you see, has a few different pieces that weren't part of our internal investigation, especially the care assessment and use of many more types of records. But it is a very similar process, and at times there's a possible push to another county if that person is found to be moved, and so this will follow the person around the state until we determine that they're either not in our state or that they're in care. If we cannot do that at the local level, then we contact the person and assess their care, and that includes field visits and every other modality that DIS are familiar with and routinely use. The care assessment process flow, again, when we contact the patient, we determine or we get a report from them about whether they're in care. That doesn't, a self-report doesn't allow us to assign a final disposition. We have to verify that with the provider or a lab result. If we can't contact the patient, of course, that's one of our final dispositions. If the person is not in care, then we go to the action and referral step. So if the person is willing to accept assistance, we go ahead and help them. If they, I think the yeses and nos are reversed on this, actually. Sorry. If they accept the CAP referral at this point, then we refer to CAP, and at the end of that intervention, a final decision is assigned, and if not, then again, they're closed out. This is just an illustration of what the LOOC screens look like. We've tried to make it so that people using the system are guided through the process and that it really closely matches the kind of workflow that they're used to. So we have, you'll see in the highlighted areas there are a lot of instructions that help people understand what to do next. And because we determine our final dispositions based on a surveillance period, that is, during a defined period, was the person resident, in care, out of care, et cetera, that information is automatically calculated when the case is entered into the LOOC system. That's the piece there in red. So that there's no, we found that as when we first started this project that there was some confusion about what to do when the person was just recently reconnected to care, although they'd been out of care when we first put the data into the LOOC system. So we've moved to a defined surveillance period where we answer the questions of interest to us. We don't depend, as I said, on the DIS, the users of the system, to calculate that, but this eliminates that particular ambiguity. And then on the care assessment piece that I mentioned, we have a mixture of both open-ended and closed-ended cases. These are required to be asked. You can't close out a case if you contact a person without filling out this part. And this has enabled us to compare our data in a very uniform way, both across the state and with our largest partner, Seattle-King County, who had a slightly different data system when we started out. So it was a little bit of a struggle to get on the same page so that we'll be able to evaluate this. But by integrating this care assessment, and it's fairly simple, but it gives us a lot of information about what's keeping people out of care. So our currently outstanding issues, we've noticed that, and I think you all know that community-based HIV testing is reported anonymously within the evaluation web system. People are asked to verify verify whether people are in care, verify whether they receive partner services, et cetera. And that's really not possible unless you have access to the surveillance data. And our community-based agencies that did the testing were reluctant to, they didn't feel that they were able to call us and mention a name because their deal with the client was that it was an anonymous, either anonymous test, which we're actually trying to close out in the state, or a confidential test. However, we determined that in the case of a preliminary positive report, that should be reported to us, and we've developed a mechanism for agencies to report preliminary positive results to us. And once we receive that, we take care of the back end of that in Evaluation Web. We complete the process and documentation in Evaluation Web because we found that in many cases it just wasn't getting done. And this is really crucial to understand whether people are getting initially linked to care. Another issue for us is we've been working through a considerable backlog of a few thousand cases over the past couple of years, and we don't really know yet what resources and workload will be when the backlog is gone and we're just doing this work routinely. So over the next 12 to 24 months, as I said, we need to get all of our information systems corralled into Maven, and that's going to be both challenging and intensive, I think, work. And I think we've done some good preliminary work in understanding how to approach a project like that, but there is quite a lot of work yet to be done. What we've learned, I think, is that it's really a good idea to go into this slowly and methodically, do the service modeling and system mapping before you start building the data system. We sort of built them at the same time, and that's difficult. The workflow of the people who are doing the investigations or in the field or in offices really needs to be closely matched with what the actual process that they have to go through to complete the work. So it really helps to involve them as you build the system, build the screens, ask them whether one piece of the process is a logical next step, and it's been very, very helpful for us to have those kinds of feedback loops. Another thing, I guess this is coming from me in particular, is I'd recommend resisting the temptation to collect all the data you might be able to collect. We've already kind of burdened people that we interview and that we attempt to help with a lot of data requests, and I think over time those have just tended to get piled up on top of one another to where some of our STD investigations and HIV partner services investigations really ask for a lot of information, and we have a feeling that actually limits the acceptance of partner services and may limit our outcomes. So try to keep it to what you actually need in order to get the work done correctly. And don't underestimate the time it takes to do that. Another thing is, as the project's gone on, we've had staff changes and we've had changes to our data system, to the LOOC system, and that's really meant that we've had to do a lot of training, retraining, and because our people are spread out in a number of areas, we are continually working to standardize their work to make sure that they're processing and documenting their work in the same way so that we'll be able to evaluate better. And we've had to have several rounds of training in order to keep that up. And so I'm guessing that we'll probably have to keep doing that forever. So that's about it. Thanks very much, and I'm looking forward to the discussion.
Great. Thank you so much, David. That was a really helpful overview. And you may need to reference some of the slides in the discussion section, so we'll keep you as a presenter. So let's open it up now to questions to David, and we also welcome any input or experience from other health departments on the line who have been in the process of developing integrated data systems as well. So we'll open up the line. If you could please announce your name and what health department jurisdiction you're from.
Hi, this is Ann Rose from Virginia Health Department. So David, thanks for that presentation. It was really good. And I just wanted to say, I think what you all are doing is, so I think it's kind of what we're trying to do, but we're not quite that far yet. So we've done some of the integration of our data systems, but we haven't gotten, and we're just starting to pilot some of the follow-up. And I guess I just have a couple questions. I'm wondering, as you've been pulling in some of your other data systems, one of the issues that we're seeing here is we're finding people in our other data systems who may not be in our surveillance system, so who may be in our Ryan White system or potentially in our HIV testing system or in some of our other databases. Have you found that issue, and how do you follow up on those? Do you follow up on those people to get them into your surveillance system?
Yes, we do. I don't know if that's happened a lot, but it does happen, especially as a result of partner services where you find a partner in the network that has HIV that has never been reported, or for some reason there's someone in the Ryan White system or the ADAP system that's getting treated for HIV and somehow it's not in EHARs. So we do contact those people and correct the system, make sure that they get in there.
Okay.
Does that answer your question?
It does answer my question. Yeah, I think we're just starting to figure out how we're going to do that follow-up for people.
Well,
and then,
it might be more convenient to work through a case manager. It might be worthwhile if we can locate if we know they have a provider to, actually go to the provider and get some of the information and develop the relationship we need. But as I said, it hasn't happened a lot for us, so.
And then.
A few cases haven't been that difficult to resolve. But go ahead.
Yeah, and then my other question is just, I think the other thing you said was that you're finding a lot of people, and I think we've heard this from other states too, is people who we think are lost at care are actually in care when you go and do the follow-up. And so how are you getting that information back into your surveillance system?
Okay, well that's in the LOOC system. So all cases that have been worked or ever dumped into the LOOC system are in an archive. They're retained, and also we do this quarterly where we do a data dump into the LOOC system, and then at the end of each quarter we look for data coming back where we need to correct something in EHARs. And then the last step of that, so that goes back into EHARs. The last step of that then is, if it happens in a successive quarter that the person comes up again, which sometimes it does, we need to correct that.
Mm-hmm.
But it's just our epidemiologist this is part of the, having the staff integration. He's the same person that works on development of the LOOC system. So it just makes it that much easier to take new information and make sure that it gets to where it needs to be.
That's great. Yeah, that's really helpful.
Okay. How about other questions?
This is Janet Tapp from South Carolina, and I wondered if you could speak just for a moment about when the DIS make contact with clients and providers, what reactions or concerns or, kind of the how did you get my name questions, how did the DIS deal with that?
Actually, we haven't gotten negative reaction in very many cases. In fact, probably the most common one that we get is some appreciation for our interest in helping them out. Once they understand that that's the reason that we're getting in touch with them. There have not been any instances that I know of in which providers objected to being contacted. Again, once they understand the purpose of this, they've been quite supportive. So, of course, we give the clients the option. They can opt out at any stage. It's just that we haven't seen very many people refusing this service. Very few people have opted out. So it turned out to be kind of a paper tiger. It was one of those things that we were quite worried about at the beginning, or slightly worried about at least, and it just kind of melted away.
Thanks. That's good to hear and very reassuring.
Hi, this is Elaine in Colorado. Really interesting presentation. I had a question about the distribution for your LOOC system. Is that now available via a web portal to all the health departments, and they are able to, do I have this correct, that they're able to independently enter and update information in the LOOC system, and then everyone is able to see that information? Is that correct?
Yes, it is a web-based system. There is a portal. Everyone has access to it. It's hosted on a server in Seattle and co-administered by us and Public Health of Seattle and King County. Everyone within the system can't see all of the system. Only the two largest health departments in the state can see across all the different sites. But each one of those sites automatically sees all of their cases that are assigned to them. So they're working through the same process using the same data entry throughout the state, and they can run reports and look at processes within their own jurisdiction, but they can't see what everybody else is doing.
Okay, but how is that assignment done where, a particular jurisdiction knows which cases are theirs when, the clients are so mobile? How do you do that?
So here's the point in the process where, actually it's back here where it says push for local investigation. So based on our best information of where that client was the last time that we had any information about them, we just push a button in the LOOC system and they automatically become part of the queue for that particular county. That's how they know that that's one of their cases. If they find,
so that's centralized.
Yes. If they find, however, during their investigation that they get good information that the person has moved or something is in another county, there is a facility within the LOOC system to re-push that to another county, at which point the county that sent it to another county is no longer able to access that record and it appears in the queue of the county where we believe that they may reside.
Okay. And how are the updates, how is EHARS refreshed with the new information that's gathered by a local jurisdiction?
Well, I have to say that that's a little bit of a jury rig right now. But we just, get the reports, the lists back out of the LOOC system and compare it with the list drawn from the criteria from EHARS, and if we have better, by which I mean more recent data in the LOOC system, it's ported to EHARS.
Okay. That's manually record by record, or is that a sort of a quarter?
No. It's done quarterly, because each quarter is when we do a data dump from EHARS into LOOC, and so then at the end of the quarter we look at what happened during the last quarter and whether that's given us better information.
Okay.
Yeah, it's done 4 times a year.
Mhm. Okay, thank you.
Other questions for David? Any other questions out there? And this is a time, because we still have some time left in the call for, as some of you are asking, general data to care implementation questions as well. So this is a great opportunity to hear from the Washington State experience.
This is Jennifer in Colorado, and I just wanted to hear a little bit about how you may link your HIV prevention data to help you with outcome measures in your evaluation of your programs.
Okay. So we're looking at, measures that are similar to some of the other ones across the country. What is the interval between someone getting diagnosed, getting into care? How many lab results do we get, or evidence of visits within 1 year? Is that up to a standard? Within the LOOC process, or the linkage-relinkage process, we have built in a few things to let us know kind of both how long that took, like what was the amount of the time that went by during the investigation, what was the result of the investigation. So we'll be looking at how many people got back into care as a result of being located, contacted, and facilitated into care. And so that then, obviously affects the information that we get from other ways of doing surveillance to determine those things. Does that make sense?
Yes, it does. Thank you.
Any other questions related to the Washington State Data to Care experience or their development of their data system?
Hi, David. This is Christian Haig from Massachusetts. Could you tell a little bit more about your lab tracker system and how it interacts with EHARS? Do you end up putting all your lab information into EHARS when you do that data migration into the tracking system? How does that work, and what do you use?
We have. I don't know exactly what what program that we use to get the lab tracker data into EHARS. But that's done before we look at, the quarterly data dump.
Oh, okay.
So, we try to, before we do that, assign or put anything into the LOOC system, we check to see whether we have the latest, what is the latest evidence that we have. What we don't have yet is the ability to refresh the LOOC system. I guess we could do this on a case-by-case basis, but I think there's going to usually be a quarterly lag if something was in the process of being reported when we initiated the dump. So when we queried EHARS, there was something out there, and there was a check in the mail, so to speak. We didn't get it until we put it into LOOC, but a few days later, after that, it's in Lab Tracker and in EHARS, but we won't know that until the next time that we query the system for, refreshing LOOC.
Great. Thank you very much.
Be nice to have that kind of faster feedback.
But that's a hard thing. It's something we're looking at too.
So I'd be curious to know how things are developing for the various people on the call today, and sort of in reference to that lay of the land question that I had, how your own environment is influencing the way you go about this.
So, David, this is Ann again in Virginia. I think one of the things that we're still trying to figure out here is we actually is like who's all going to do our follow-up for loss to care. So it sounds like your DIS are doing most of it there, but our DIS I think we have fairly limited DIS, and they're and so we're working to try to get some resources to hire DIS who are mainly going to be focused on loss to care, but we have a lot of community resources. I think we have patient navigation that we're funding through care and prevention that we're trying to figure out if we can use those resources to do loss to care follow-up. But I think, we're still sort of struggling with, who can they do what information can we share with them? We had a discussion with CDC last month. We had an HIV surveillance site visit, and we actually talked through with them some of these issues about, if we have someone who's lost to care who hasn't really had, any care for a few years, and we really don't have a site that they're associated with, who do we ask to do that follow-up? So I think that's one of the issues we're still trying to figure out. I think I think we have to use DIS in some cases, especially if a person's never been in care. But I think we're trying to figure out how we can use some of our patient navigation sites in the community as well, and if we can share some of that loss to care information. But I think for us that we have to have some information that a person was associated with that site at some point before we would be able we're trying to get some data sharing agreements put in place to be able to share data. But I think really what we heard from CDC is that I think we do really need to have some information at some point that a person had received care at a site.
So I think we draw a bright line between what surveillance information and then what's available to community-based organizations that either do relinkage services or patient navigation. That's a sticking point for everybody, I think. So, right up to the point where we find and locate a person, it's all within health jurisdiction, either state or local.
Mm-hmm.
And if we can get, if the person, and we found really that quite a lot of people can be linked to care by that person, sort of right at the time, because, one of the big reasons that you'll find people are out of care is they don't have insurance. So at that point, you can refer them to a Ryan White case manager or a patient navigator. As long as they give you their assent to doing that, then you can share information about that person that has that need with the agency in their locality that can help them. But, we haven't found a way yet to actually have the community-based organizations be the first contact. We have to, keep that. We can't let that surveillance data out of the bag, and that is kind of a frustrating thing.
Yeah, I think that's where. Yeah, I think that's the point. I mean, yeah, we are just using GIS now, I think, to do the piece of trying to find the person and then refer them, and I just had a call with GIS a couple hours ago, and that's what they were saying. Really, that's what they're trying to do, is kind of make that initial linkage and get them referred to the patient navigator, and then have the patient navigator kind of do all the the follow-up to make sure the person gets into care and stays in care. So I think it's great to work that way. Yeah, because the case managers and patient navigators are very skilled at doing that. It's just to set up that referral process so that it's a very warm handoff, so that there's some kind of accountability about whether that was completed. I think once someone has a case manager, there's a very good chance that they'll get into care. Same with a patient navigator. But we still need to be able to verify that happened, even if we're working through one of those other actors. And there's where it comes in handy to be so connected to our care services here and have access to the CareWare system, because we can actually look into that directly here. Yeah, that's nice. That's a good thing, and we have managed to get our Ryan White system linked in here as well, and then we put in this active referral system at the beginning of this year for all our DIS. So whenever they link a person's diagnosed, they send in there's this form that they send in to us that tells us who they referred. They fax it to whoever they referred the person to, either a patient navigator or a medical site if there's not a patient navigator available, and then the patient navigator actually sends it back when the person has their first medical appointment. So the DIS also knows that they made their first medical appointment. So that seems to be helping, I think, with us getting that information initially. And there's a consent that goes with that as well.
That consent is the point at which the information flows away out of surveillance and into community service. We don't use the paper form. It's all kind of automated within LOOC, so the final disposition would be referred, who they were referred to, and then we look at this end about whether it got completed.
Mm-hmm. Yeah, we'd like to get, I think we're hoping to go electronic soon. We're hoping to get there. We're just our local health departments are not very electronic at this point, so we are actually moving to Maven too. So we acquired it and we're migrating our STDMIS to it. So we're hoping all the local health departments will have it in the next year or so.
That's great.
Yeah, it'll be nice.
Would anyone else like to share what they're working on in terms of these activities and the lay of the land, as David referred to?
Hi, this is Monita from South Carolina. We're in the early stages of identifying what we're going to do with data to care and what we can actually do with implementing it. We're working together, care, prevention, and surveillance, to kind of roll out our plan. We had yesterday our first meeting, our think tank meeting, with some community CBO executive directors, and that went really, really well, just getting their input and their thoughts on what they foresee the data to care model potentially looking like. My question is as well, did you do any community, I'm sure you did, engagement activities, and what were some of the outcomes initially? And if there's any resistance, how did you all overcome that so that you can find a common ground and be able to implement data to care?
I guess there were three players that we really needed to do some prep work with. One was providers, healthcare providers, and that work primarily needed to happen in Seattle, King County, where that's where 50 to 60% of all the cases in Washington are located. So there are a fairly small number of providers there that have really big caseloads for patients. And so when King County did a pilot of this work about 4 years ago, they went through an initial round of contacting providers, getting a lot of feedback from them, and kind of assessing that, and then making sure that they were responsive to the concerns that they heard during that process. For us, and the second group that we needed to work with was the local health jurisdictions. One of their concerns was, there's been sort of a lot of renegotiation of what the role of public health is versus community-based organizations as we've moved more into the area of data-driven services. Certainly local health jurisdictions are very much on the data side, and yet they would also be called upon to do some of the linkage work. And they were concerned about the skill set of their people, and they were also concerned about whether they would have sufficient resources to bring this about. So we responded to that by providing training, technical assistance, and adding money to their contracts that was specifically earmarked for this work. Community-based organizations, their concerns were, they're moving from a more process-oriented behavioral intervention model to something where they're really accountable for outcomes. And I think we're a little bit resistant to that change, a little bit anxious about whether they could be successful. But in the end, they began to see a lot of opportunities, particularly as the ACA began to take hold here. They've done some very entrepreneurial things to position themselves to provide patient navigation and do outreach to get people insured and things like that. So they really have found a fit within the system of providing those services that are done really in the field, like helping people get to appointments or making sure that somebody gets linked to a case manager and perhaps working with them during the initial period where they're even getting integrated into case management, or if they don't have a case management, to be a third party acting with them with the provider. So they have, since they have historically seen themselves as advocates for their population, they've taken very well to this idea of being an advocate for individuals who are in this process. And actually, one of our largest organizations, community-based organizations here, changed their name to include the word advocates in it, just to emphasize that. So we did a lot of meetings with all of our contractors, with LHJs to discuss this, with community-based organizations to discuss this. We had meetings with them together to sort out their roles. We went to the sites, to the jurisdictions themselves, and sat with people at the jurisdictions and, again, joint meetings with CBOs. So there was a lot of that kind of legwork involved at the beginning.
Yeah, I think that's where we are now. We'll have a follow-up meeting with them that will actually be face-to-face so that we can really explain kind of what, we're looking at. So that was very helpful. Thank you.
Great. Thanks for the discussion and sharing. We have time for one more question or sharing of an experience in another jurisdiction. Anything else? Okay. I think we will wrap up the webinar today. I just want to extend an enormous thank you to David for pulling together such a comprehensive and useful webinar, and for all of the health departments who joined this final webinar and for the rich discussion. We will be sending you an online evaluation and look forward to your feedback. And also, if you'd like a copy of the recorded webinar, please let your TA specialist know. I just want to check with Rondette and Kathleen from CDC and see if they have any further comments before we close the call.
This is Rondette. I don't have any further comments other than to just thank everyone for their participation. I think this was a great call, and I was so happy to hear the questions that came from the jurisdictions, and people got a lot out of the information. Thanks again to David for a great presentation. This is my second time hearing it, and I enjoyed it as well the second time. Thank you again.
Great. Okay, so thank you all again for joining the webinar, and again, a special thanks to David Heel. Bye-bye, everyone.
Bye-bye.
I'm going to go back in.